Let's start with the stromal neoplasms of the breast. The breast has two types of stroma, the intralobular stroma and the interlobular stroma. Tumors of the intralobular stroma includes fibroadenoma, which is the most common one, and phylloides tumor. Both of these tumors are biphasic tumors, which means that they are composed of stromal cells and epithelial cells. As the neoplastic proliferation of the specialized lobular fibroblasts that are seen within the intralobular stroma will also stimulate a reactive proliferation of the lobular epithelial cells. As the intralobular fibroblasts proliferate, they're gonna push and distort the epithelial cells. فالepithelial cells they're gonna form like elongated slit-like structures rather than forming the round acini. The specialized stroma اللي هي الانtralobular stroma elaborate growth factors that will result in a proliferation of the non-neoplastic epithelial component of these tumors. So the neoplastic component of fibroadenoma and phylloides tumor is the stroma, while the non-neoplastic part is the epithelium. But the epithelium is stimulated through the growth factors released by the specialized stroma, and so it's gonna proliferate. But the neoplastic part of these tumors is the intralobular stroma, the specialized cell in the stroma. The tumors that arise from the interlobular stroma are monophasic tumors, which means that they are only composed of mesenchymal cells. Now, the interlobular stromal tumors include some types of tumors that are found in other sites of the body, like lipomas and angiosarcoma, and also types of tumors that are more commonly seen in the breast, like the pseudoangiomatous stromal hyperplasia and the myofibroblastoma. The only malignancy that is derived from the interlobular stroma is called angiosarcoma. Let's start with the fibroadenoma, which is the most common benign neoplasm of the female breast. This tumor is related to the estrogen activity because it's composed of the specialized stroma that responds very well to the elevated estrogen levels. So this tumor may enlarge late in the menstrual cycle and during pregnancy, and when the levels of the estrogen goes down after menopause, they're gonna regress and calcify. The peak age of incidence is like the reproductive age ladies between the age of 20s and 40s. Usually the patients present with discrete, well-circumscribed, well-defined solitary masses that are freely movable within the breast tissue. And so the size ranges from 1 centimeter to 10 centimeters. And usually this lesion is easily shelled out surgically. فبالتالي a surgical excision is easy because it's well-defined discrete mass. This figure shows the gross appearance or the macroscopic appearance of the fibroadenoma. The white arrow here points to the fibroadenoma, and as you can appreciate, it's a very small mass here, but it's well circumscribed, well defined, and discrete and easily detectable if compared with the background breast tissue. Now you may wonder what is the blue color here. This is the blue dye that is used to mark the lesion during the fine needle localization in radiology, so that the surgeon could find the small masses within the breast tissue easily. This figure shows you the microscopic appearance of the fibroadenoma. As you can appreciate, it's a proliferation of the intralobular stroma. The intralobular stroma is increasing in size here and in cellularity, and this gonna push and surround the adjacent epithelium. So the epithelium will be compressed and form the slit-like spaces here. So you have overproliferation of the intralobular stroma that will result in distortion of the architecture of the ducts and the lobules. But look here, the border or the boundary between the fibroadenoma and the adjacent breast tissue is sharply defined because this lesion is well-defined lesion if compared with other tumors that we're going to discuss in a minute. Phylloides tumor, on the other hand, is another intralobular stromal tumor. However, it's much less common than fibroadenoma. And this tumor that comes from the intralobular stroma does not arise from a pre-existing fibroadenoma. Mostly your patient is an older age lady in her 6th decade of life, and the lesion shows leaf-like clefts and slits due to the presence of nodules of a proliferating stroma covered by the epithelium. Phylloides tumor is classified according to certain histologic findings into benign, borderline, and malignant phylloides tumor. The histologic criteria to diagnose benign or borderline or malignant phylloides tumor depends on the stromal cellularity, the presence of atypia, the presence of stromal overgrowth, the number of mitoses, the tumor border if it's like well-defined or infiltrative, and the presence of malignant elements. Benign phylloides tumor, which is the most common type of phylloides tumor accounting for about 60 to 75% of cases, are associated with rare recurrence and they do not metastasize. While borderline phylloides tumor, which accounts for about 15 to 26% of the cases diagnosed with phylloides tumor, they carry higher risk of local recurrence than the benign phylloides tumor. But the risk of metastasis is still present, but it's very low. Compare that with the malignant phylloides tumor. Malignant phylloides tumor accounts for about 8 to 20% of the cases of phylloides, and about 23 to 30% of the cases they have the risk of local recurrence, and 9% of the cases they have risk of distant metastasis. This figure shows the histologic findings in phylloides tumor. As you can appreciate here, you have more cellular stroma pushing and distorting the adjacent ducts and lobules and forming leaf-like structure مثل أوراق الشجر إذا بتلاحظوا هون. So the clefts looks like leaf-like spaces and the stroma bulges into these spaces. Look to the boundary between the adjacent tissue and this phylloides tumor. It's like permeative, so it's not like little bit infiltrative in these areas, but it's not well defined as what we saw in fibroadenomas. So the cellularity has increased. There is more atypia if we have a higher power view and mitosis in this figure.